Robley Rex VM Medical Center. It is a great pleasure for me to introduce today's speaker, who is Dr. Syed Abbas. He is currently PGY 4, and actually he's going to be graduating in a couple of weeks. He is also my long-term supervisee, and it's always great pleasure working with him. Just a little bit about Dr. Abbas. He was born in Pakistan and raised in Buffalo, New York. He completed his undergrad degree at the Kansas University, Buffalo, New York, in cellular and molecular biology. He attended Spartan Health Sciences University in the West Indies. He completed his MBA in healthcare administration while in medical school at the Davenport University in Grand Rapids, Michigan, and he worked in an administrative capacity prior to the residency. During his residency and when he was PGY 2, he was awarded John Bell Award for his great work in emergency psychiatric services. He was involved in teaching for our medical student at GeoWell School of Medicine. He also worked on some articles which were published, and he did it in collaboration with Dr. Lipman. Upon graduation, Dr. Abbas will continue to practice in an administrative and clinical capacity. He has accepted the directorship role at the Central Alabama VA in Montgomery, Alabama. Dr. Abbas has a special interest in geriatric psychiatry, which reflects in his presentation for today, which is about dementia. So without further ado, please welcome Dr. Abbas.
Thank you, Dr. Solomon. I just want to make sure everybody can see and hear the presentation okay. And so, yeah, today, it's been wonderful to train here at the University of Louisville, and thank you for giving me the opportunity to talk about a topic that I'm very interested in, and it makes a big impact into people's lives. So today we're going to be talking about dementia, just taking into account the psychiatric considerations that come with dementia, both mild, moderate, severe dementia, and how mental illness affects our risk factors and what treatment options are available and what's coming down the horizon. So disclosures, I have no financial interest. I have no financial interest or conflicts to report, and I will discuss medications that are in development or in investigation for approval by the FDA. So just to kind of start off on a lighter note, comic. I'm not losing my memory. I'm just living in the here and now. I think this was a cartoon from the New Yorker. Just trying to make a little bit light of the growing geriatric population in this country, and probably their biggest subscribers. So objectives of this presentation will be, we'll talk about dementia diagnosis and stratification, clinical versus pathological diagnosis of dementia. And that could be a grand round on its own, so we won't get too much into it. We'll just briefly mention some genetic and markers that are available for testing. Is this better? Oh, perfect. Okay. Okay. And then we'll talk about some risk factors and modifiable, non-modifiable risk factors for developing dementia illness. Talk briefly about disease-modifying therapies, and then a little bit of a chunk of it will be about the neuropsychiatric symptoms in dementia and the management. So we'll start off with like a brief history. Alois Alzheimer. So he was the first to really describe the pathological features of pre-senile dementia. They had the famous case is of Auguste D. She was her husband had brought her really to this German hospital because he had noticed like paranoia of that he was he was, that he was cheating on her, disturbance of memory, aggressiveness, crying, confusion. And so in 1901, she was admitted to a German hospital and evaluated by Alzheimer's. So, she had a pretty severe loss of function. She was making errors in her finances, was a regular bookkeeper. And she was only 50 years old, and she was making errors as a homemaker, not remembering recipes, and then taking care of the home. So she increasingly deteriorated. She was admitted to the hospital for like 5 years, and then she eventually died in 1906. And at that time, Alzheimer was able to like investigate her brain, both morphologically and histologically, and the results of that evaluation and the relationship with her clinical findings were the basis of Alzheimer's findings. And he presented these findings to a conference in Germany, and it didn't really get too much attention. It was pretty overlooked, and nobody really heard anything about it until Emil Kraepelin, his mentor, published his textbook, 8th edition, and he included the case in there. I mean, this was hundreds of pages of text, and he had just published Alzheimer's case, and he dubbed it Alzheimer's disease. So this book was basically just a case set studies of early onset dementia, pre-senile dementia, because I think at that stage there was difficulty in distinguishing what we know as pathological dementia now to a severe form of just age-related changes. And so, at the later stages, insanity, and these folks are usually admitted to the insane asylum. So, in this case study, there was a rare and unusual finding that looks like senile dementia, but in a younger person. So that was a thing of interest. But one thing I think it's important to note is that it was concluded at that time that there were some changes in the brain histologically, and this was very new, sort of techniques at that time, the staining and pictographs of neurons that it was causing some clinical correlations and clinical symptoms. But it wasn't until 1970 that at that point they were just indicating that this pre-senile dementia was what was leading to the clinical picture due to the pathological findings. But it's not really till the 1970s we found out that both the pathological findings are pretty similar in both pre-senile and senile dementia, which is after the age of 65. One important person to also mention that doesn't get really too much or any notice, I think, is Solomon Carter Fuller. And he had some really interesting work back in from the 1903 to 1911. So we don't know much about him, but he worked in Alzheimer's lab from 1903 to 1905. He was a pathologist by trade. He was a grandson of former American slaves that had once, returned to Liberia, and then came back to the United States in at age 17. So he was a pathologist at heart, but eventually he trained in the U.S. but went to Germany to study pathology further, brain pathology, in fact, and worked with Alzheimer there. And at that time, that was probably the best place in the world you could do that. So he was really like at the doing like groundbreaking work there. And what's unique about him is that he had studies that for his time in like the Journal of Insanity were way more scientific than usually other articles that would be in there. And the other articles would be labeled stuff like, why are Jews so anxious, or why are Negroes so happy? And so, but he actually, put things like, actually like staining and clinical correlation. And sometimes if you look at some of the articles that he published, they look like contemporary work. which was really fascinating for the time. So he first saw on autopsy that pathology is shared between both the presenile dementia and senile dementia. And this was because, you know, he continued to do his pathologic assessment on brains of folks that had passed away in Germany. And he first made the conclusion, well, going back first, he first made the conclusion that there was a correlation between pathology and clinical records. So he not only just did pathological work, but, you know, the brain that he would stain and look at and find these things, he would go back and look at the clinical records. And he would, he noticed that, hey, you know, sometimes these folks are diagnosed with this, you know, senile condition, but they don't have any plaques. And sometimes these folks are diagnosed with, you know, presenile or senile sort of dementia, and they do have plaques, or there are plaques and they're not diagnosed with any sort of, you know, senile findings at all in the record. So he was the first one to sort of conclude in an article in 1911 that plaques were neither necessary or sufficient to cause dementia pathology, and we didn't really catch up to that till the 1970s, and in the like in the neuropathology sort of world. So yeah, that's just really interesting. It was way ahead of his time. We don't know a lot about him, just for, you know, obvious findings of the time, just like institutional racism and you know, inability to advance. I think he worked as he did all the work of a pathology department chair at Boston Medical School for 5 years until they hired somebody else younger and less experienced, and he stopped doing that work, but they never gave him that title. And so we're still arguing about this today, right? The you know, is the senile plaques, amyloid, is that causing the dementia symptoms, right? And so that's why we have so much research in different sorts of venues. We have monoclonal antibodies trying to remove plaque aggregates. We have anti-inflammatories. We're looking at different receptors. So we're still really arguing. We're still mulling over that question, if that's really what's going on. All right, so a little bit of history. Hopefully everyone's still awake. All right. And so, you know, this is just more of a detailed streamline of research in Alzheimer's disease. 1906 to 2023. Just a couple of notable things here. You know, introduction of the cholinergic hypothesis in 1982. Clinical criteria for probable Alzheimer's dementia published in 84. APP gene identified in 87. First acetylcholinesterase inhibitors as Alzheimer's disease therapeutic drugs in 93. And, you know, not really happened too much between 2004 and 2022-ish, until the FDA, you know, did a rapid accelerated approval of donanemab in early symptomatic Alzheimer's dementia, which, you know, we'll talk about a little later. And more recently, was an accelerated approval of aducanumab, both of them considered, you know, one of the first FDA-approved disease-modifying drugs for symptoms of dementia and progression. So talking about dementia, prevalence-wise, approximately 7 million people over the age of 65 in 2024 are diagnosed with dementia. About 73% of those people are over the age of 75. 1 in 9 over the age of 65 has Alzheimer's dementia. Percent of individuals with Alzheimer's dementia increase with age. 5% about age 65 to 74, 13% about 75 to 84, and 33% over the age of 85. The number and proportions of Americans expected to be diagnosed with dementia continues to grow. It's expected that Americans over the age of 65 will grow from 22 million to 58 million to 82 million by 2050. And that's just in the United States, right? And then baby boomer, the largest and oldest of the generation, their oldest members turned 75 in 2021. But it's not all bad news. We'll talk a little bit about how incidence is actually a little better. And then we got a little handy graph here, kind of indicate, given that visual of how many people right now are diagnosed with Alzheimer's dementia. This is a recent figure of January 2024. A nice little chart here of the expected growth, what we can see by 2060 of the geriatric population. You can see the highest sort of growth is going to be in the ages 85 plus, which 4 to 13 million will make about 7 million folks in 2060. So yeah, we can expect the prevalence obviously to increase. We're not sure what the incidence will show, and then data from COVID is still kind of pending what kind of impact that has had on the diagnosis and development and progression of dementia symptoms in folks that are were already diagnosed. So incidence-wise, recent studies indicate that the incidence has actually declined, and that's attributed to some improvements in the 20th century and us doing kind of a good job with the modifiable risk factors. So we have increased prevention of treatment of hypertension and cardiac risk factors, and people are getting like a greater educational achievement. There's lower rates of smoking, lower rates of poverty and chemical toxin exposures. And those all, have some promising information, because that means we're correctly identifying some of the risk factors, and reducing those risk factors appears to be effective. Some things to be unsure of, how obesity and diabetes will change this trend as those continues to increase worldwide, and then impacts of COVID, are yet to be seen. Yeah, so basically addressing modifiable risk factors is really just thought to develop a higher cognitive reserve. So more education and better health just leads to a higher starting level and tolerance to neuropathology. Other thing, we'll talk a little bit in detail later of the risk factors. Another little cartoon. Short-term memory loss support group. Good evening. You're probably all wondering why you just walked into this room. Again, more boomer humor. All right. I think it's important to address the costs of care, of dementia care across all spectrums. Total cost is about 20, as of 2024, aggregate is 360 billion, and that's just taking into account, the costs from Medicare, Medicaid, out of pocket, and private insurance, but it doesn't really take into account the caregiver impacts to the economy and those costs, which are expected to also be pretty high. There's fear that as the geriatric population grows, their care needs will basically bankrupt Medicare and also Social Security income. Important thing to know is if you just have Medicare, if you don't meet the income criteria for if you don't meet the income criteria for Medicaid, Medicare only really covers about 90 days of nursing home care. And after that, it's usually self-pay. People have to divest from their property and their cars and their bank accounts. Usually end up draining their retirement in a few years, if that. On average, full-time nursing home care usually runs around over $100,000 a year. And part-time home health care runs anywhere from 25 to 40,000 a year for folks that need that. So defining dementia, the term major neurocognitive disorder in the DSM-5. Um, um, it's basically any cognitive or behavioral symptoms that limit somebody's ability to perform their usual activities, ADL or instrumental activities of daily living. It represents basically a decline in function from the prior level of function and performance, not obviously explained by delirium or a major psychiatric disorder, and an objective decline at least a minimum of 2 major cognitive domains. Now I've included here just like a brief image here of the different types of cognitive domains. And we do this every day when we evaluate a patient. We're whether we know it or not, we're assessing some cognitive domains. When we see a geriatric patient, somebody with delirium, dementia, we do a more thoroughly assessment. And so learning and memory, including free recall, cued recall, recognition memory, semantic memory, autobiographical long-term memory, and implicit learning. Language includes word finding, fluency, grammar and syntax, object naming and repetitive language, complex attention, such as sustained attention, divided attention, selective attention, information processing speed. And then we also test cognitive domains in motor functions, such as visual constructional reasoning, visual perception, perceptual motor coordination, executive function, such as decision-making, planning, working memory, inhibition, and response to feedback. We tend to see that decline much in the later stages, unless it's some other variants that etiology of dementia, such as frontotemporal dementia. And then social cognition, such as recognition of emotions, theory of mind, insight. The DSM-5 does have some specifiers to the major neurocognitive disorder that dubs them mild, moderate, or severe, and then additional with or without behavioral disturbances. So mild usually indicates that difficulty in instrumental activities of daily living, such as housework, shopping, money. Moderate includes difficulty in additional basic activities in addition to the mild, such as feeding self, dressing self, bathing himself, and then severe is fully dependent. Continuing on, the DSM-5, offers levels of diagnostic certainty, probable and possible. Probable if the patient meets, an evidence of causative dementia disorder due to either genetic, family, or testing, or 3 of the following, which is clear evidence of decline in memory and learning, as well as one or more cognitive domain. Steady progressing and gradual decline, and no evidence of mixed etiology. Possible is if the above criteria are not met and you have 1 or 2, and you have a clinical suspicion. So some examples of neuropsychological tests that we use to formally test cognitive domains. There's quite a few of them, but the one we're most familiar with and includes different portions of these tests is the MoCA, Montreal Cognitive Assessment. Of course, we don't usually typically, carry a MoCA in our pocket everywhere we go, and sometimes we might not even be sure that we need it. So it's important to kind of come up with your own cognitive assessment, at the bedside that you can do. Excuse me. But these are just a lot of these are also used in clinical trials, and so I won't go through all of them. Just know that they exist. Some of these will be on your pripe for the folks that will be taking it in a few months, and so might be interested to learn a little bit about them. Here's our MoCA. This kind of briefly visuospatial, executive, language, working memory, attention, memory, and orientation. And I'm sure like everybody in this room has done it at least once, and kind of knows how that goes. And then we want to talk about the difference between mild and major neurocognitive disorder according to DSM-5. So mild neurocognitive disorder is symptoms progression in 3 stages of neurodegenerative dementia. There's the pre-symptomatic stage, there's the early symptomatic stage, which can be dubbed as mild cognitive impairment, and then the later symptomatic and dementia stage, which starts with mild neurocognitive disorder going to major neurocognitive disorder. And each of these have their own, like, as it progresses to major neurocognitive disorder, then you can start assigning the severities. So major neurocognitive disorder we already discussed. The difference is there's a significant cognitive decline in major and a modest cognitive decline in mild neurocognitive disorder. In mild cognitive disorder, the cognitive deficits do not interfere with the independence in daily activities. The complex instrumental activities of daily living are preserved, but may require greater effort, some compensatory strategies or accommodation, and there's no severity specifier for mild neurocognitive disorder. And then mild cognitive impairment, just a overview of that, so we're all on the same page. Symptoms include a concern from a patient or a family member about their memory or ability to perform usual activities. It's not explained by delirium or major psychiatric disorder like depression, which can have pseudo-dementia or pseudo-cognitive impairment. There's an objective decline and a minimum of one major cognitive domain that we discussed earlier. And sometimes it's regarded as a possible prodromal state for several dementia disorders. It can be difficult to differentiate from normal aging. So folks should have regular follow-ups and a MOCA or some sort of cognitive assessment every 6 months. It can overlap with mild cognitive disorder, and about 10 to 20% of cases go on to progress to mild or major cognitive disorder each year. And so just overall, getting an impression of the clinical course of dementia, you'll have some sort of, proteinopathy, which will be pretty insidious up until really you develop mild cognitive impairment, which will then have a much more rapid progression to major neurocognitive disorder or dementia. And so the point, I think, the goal right now of some of the monoclonal antibodies is to really treat in this stage here, or even in this stage here, to not reverse any findings or neuronal damage, but really to stop or slow progression. And then I think it'd be a good idea to just kind of discuss each, not each, but some etiological subtypes of dementia. Obviously, we're not going to talk about all of them. It's a vast topic. It could be several presentations on its own. But briefly, Alzheimer's disease, just for some educational information for the residents and students. Accumulation of tau beta amyloid. This accompanies neuronal death and damage to brain tissue, inflammation and atrophy of the brain are some changes that are seen. Alzheimer's now is the most common cause of dementia. It accounts for an estimated 60 to 80% of cases. And we'll talk about that number in a little bit because we have to differentiate between clinical and pathological Alzheimer's disease. And we do end up finding that of the majority of folks that are diagnosed with Alzheimer's, a lower percentage actually have the pathological findings. So symptoms, difficulty remembering recent conversations, names, events, apathy, and depression are early symptoms. Very significant, limitation in functional mobility, even just from those things. Communication problems, confusion, and poor judgment and behavioral changes may occur next. And then in the severe phases, you have difficulty walking, speaking, and swallowing. The next etiology to discuss is cerebrovascular disease. Basically, chronic ischemic blood vessel changes, either from a brain injury, right? That's a risk factor. More commonly with moderate to severe brain injury, increased likelihood of developing a dementing illness rather than mild. But the biggest risk factors is uncontrolled hypertension. And so the incidence of cerebrovascular disease has been dropping due to better antihypertensive control. So people who develop changes, related to these are said to have vascular dementia. This accounts right now about 5 to 10% of individuals with dementia, but it is more common in a mixed pathology too. And so some symptoms you might see in typical cerebrovascular diseases: slow thoughts or impaired ability to make decisions, plan or organize, maybe some of the initial symptoms. Memory may also be affected. Some people with vascular dementia may become less emotional and have difficulty with motor function, especially a slower gait or poor balance. Frontotemporal dementia, I think everyone kind of knows about that, occurring much earlier. Nerve cells in the frontal and temporal lobes die and the lobes shrink. Upper layer of the cortex soften. There's abnormal amounts of tau or transactive response DNA binding protein are present. About 60% of people with frontal FTD are between the ages of 45 and 60. In about a systemic review, frontotemporal dementia accounted for about 3% of dementia cases. That included people 65 and older, and about 10% of dementia cases that restricted those to younger than 65. And typical early symptoms include, marked changes in personality and behavior, difficulty with producing or comprehending language, and memory is typically spared in the early stages of disease. So these folks would do pretty well on a MOPA. And, you might say there's nothing wrong, they're just a jerk or something like that. Parkinson's disease, about 3.6% of dementia cases were due to Parkinson's disease, and about roughly 25% of folks diagnosed with Parkinson's disease develop Parkinson's dementia. And so clumps of, alpha-synuclein appear in deep brain structures, specifically as substantia nigra, and they cause degenerative, nerve cell changes that reduce dopamine activity. As it progresses, alpha-synuclein can progress to other areas of the brain as well, and the cortex. And so obvious symptoms of Parkinson's you'll see with the slowness, rigidity, tremor, changes in gait. Cognitive symptoms tend to occur later, typically years after movement symptoms appear. Some mixed pathologies. This is the last one of the subtypes. I don't think there's much utility in going into way more of them, although that would be interesting to talk about. So mixed pathology is usually when an individual shows brain changes of more than one cause of dementia. So more than 50% of people diagnosed with Alzheimer's dementia who were studied at the Alzheimer's Disease Research Center had actually mixed dementia. In community-based studies, the percentage is higher. Mixed dementia is most common in folks age 85 or older. And so this is, a combination of all the other ones and even more that we discussed earlier. Symptoms really just vary depending on the brain changes present. And then lastly, I'll just talk about briefly Lewy body dementia or Lewy body disease, where alpha-synuclein clumps develop in different parts of the brain. Dementia can result. About 5% of individuals with dementia show evidence of Lewy body dementia alone, but most people with dementia with Lewy body have the pathological changes you typically see in Alzheimer's dementia. Early symptoms can include sleep disturbances, visual hallucination, visuospatial impairment. They may change dramatically throughout the day. There are some motor functions, and these folks are obviously very, very sensitive to antipsychotics, and sometimes that can be kind of a diagnostic thing that can point the direction towards exploring that more. Okay, nice little image to kind of just talk about the overview of vascular and then proteinopathies involved in cognitive decline. I think I don't think the where they are kind of correlates with where it happens in the brain. I think I just put that there. And so things we didn't really talk about, ALS, late corticobasal syndrome, primary age-related tauopathy, and Huntington's disease. All sort of really interesting things to read up about. And then going back to to give an overview of the diagnostic criteria that we discussed earlier. You could just kind of do a timeline just for Alzheimer's dementia. We have your preclinical Alzheimer's dementia. You don't have symptoms, but possible biological changes in the brain. Why would we even know about that? Okay, we got family history or genetic history, or we're concerned, or a family member or loved one, our friend is concerned, or your physician's concerned. So they do the investigations. Progresses to mild cognitive impairment due to Alzheimer's, very mild symptoms. Either mild cognitive impairment or mild cognitive disorder. So may not interfere with everyday activities. Dementia due to Alzheimer, mild, so symptoms start to interfere with some activities. Moderate symptoms interfere with many activities, and then severe symptoms interfere with most activities and require full care. And so dementia-like symptoms are going to be important to take into consideration before we, start treating or working folks up for dementia. And so we will be including like untreated sleep apnea, delirium side effects, effects of medications, polypharmacy, Lyme disease, thyroid problems, head injury, vascular issues or tumors, vitamin deficiencies, and alcohol-related dementia-like symptoms. Most of those are reversible except for, if we obviously have a long history of alcohol use. Some list of non-reversible versus reversible etiologies. Basically, most of the ones that include the proteinopathies. And I don't agree with HIV dementia being on here, but there is evidence that, treatment with HIV therapy can help improve cognitive function, but the rest of them, they're recurring, and loss of neurons was typically non-reversible, and then reversible etiologies, like we discussed in the previous slide. Discussing some normal aging and structural changes. We have to differentiate dementia from normal aging. MRI studies reveal as we grow older, our brain volumes decrease, our gray matter loss is more pronounced, our length of myelinated axons are reduced by up to more than 50%, but the occipital cortex is mainly spared. Some cognitive changes that we'll see in normal aging is decline in episodic, semantic, and working memory, slower processing speed, etc. But one thing that happens is we do see an increase executive functioning impairments as we age. And this is a nice little handy chart just indicating everything I said above. One structural changes that you might also see is enlargement of the ventricles due to the volume loss, reduction of synaptic spines, decrease in the number of synapses, and that's important to consider when we treat geriatric folks with psychotropic medications, because they have less brain, basically they have less synapses, so we may need to make adjustments and kind of be more wary of the sensitivity to psychotropic medications for the elderly, just because of the normal aging and changes in brain structure. And so just kind of comparing some of the signs of Alzheimer's disease with normal aging. So memory loss that disrupts daily life is, pathological in Alzheimer's, leading to loss of function, asking the same question over and over, needing to rely on memory aids, compared to just normal aging, we're finding in those things. Changes in planning or solving problems. Some people experience in Alzheimer's disease changes in their ability to develop or follow a plan. They have trouble following a family recipe or keeping track of bills. In normal aging, you may make occasional errors when managing finances or household bills. In familiar tasks, as Alzheimer's progresses, find it hard to complete those, such as driving to a familiar location, organizing a grocery list, or using an appliance that they once knew how to use well. Whereas in normal aging, you occasionally need help with some of the things that you used to do, like deal with new technology or a new appliance or something like that. I'm sure if you guys have like older parents, you're always helping them with like the internet or their smartphones. Confusion with time or place. Folks with Alzheimer's disease can lose track of the dates, seasons, and passages time. Normal aging, we might just get confused about the day of the week, but we're able to rationalize and figure it out later. Yesterday was Tuesday, and that was the first, and today is Friday. Well, that makes it this many days have passed, so it must be this date. Trouble with understanding visual images and spatial relationship. That can be a sign of Alzheimer's, dementia. Judging distance and determining color and contrast cause issues with driving. And then in normal aging, we can have vision changes related to cataracts. And then just sort of continues like this. So I don't have to go through the whole thing. There's an equivalent of normal aging change to Alzheimer's dementia changes, and they're very distinct. We want to differentiate delirium and dementia, although it's important to recognize delirium and dementia can interact in very complex ways. Just very briefly, delirium is acute, subacute, in the setting of metabolic derangements or infection. Dementia is very gradual. Level of awareness is waxing and waning. And whereas in dementia, it usually preserved, but dementia with Lewy body has some fluctuations. Circadian rhythms are severe and pronounced, the disruptions in the circadian rhythm. Whereas in some dementias, particularly Parkinson's disease, dementia, REM sleep behavior disorders are common in those alpha-synucleinopathies. And then hallucinations and delirium are typically common and threatening. They're very disturbing to the patient. They lead to agitation. They cause interference with their care. Whereas in dementia, the hallucinations aren't threatening. They may be sometimes, but most of the time, the patient usually sees insects, or you may see a person, or but that's usually not the case with dementia with Lewy bodies. Now, one important thing to really do consider with how delirium and dementia interact is that, if delirium does occur in somebody with modified with dementia or diagnosis of dementia or early stages of dementia, you can see an acceleration really in the underlying neurodegenerative pathology that's already existing in that individual. And so prolonged delirium, may lead to somebody that already has mild or major neurocognitive disorder to have a new baseline, basically. And that's something that we need to recognize more often, that these folks may not go back to what they were prior to this 2-week-long, 1-month-long delirious episode. So prevalence of delirium together with dementia is about 48% of hospitalized patients, according to our recent meta-analysis. The prevalence rates vary due to different diagnostic approaches and the overlap of dementia and delirium symptoms, and so they could be higher than that. Mentioned earlier, dementia is a leading independent risk factor for delirium. Delirium in people with dementia is mostly in the acute hospital setting with unfamiliar places, unfamiliar people, and then use of medications like anesthesia. So other things that can predispose to adverse outcomes following delirium is the increased length of stay, worsening cognitive and functional outcomes, and increased risk of institutionalization and mortality. And this little chart here is basically just what we discussed earlier with the interaction between dementia and delirium, acceleration of pathology. So dementia, depression, and delirium is also an important distinction to make. Basically, in depression, you'll have much of the combination of features of both dementia and delirium. And so I included this chart in here just to indicate that it's not just dementia or delirium we have to look out for. We may get consulted on the medical service for somebody that maybe in a delirious state or maybe have dementia, and they may have depression on top of it. And we'll talk a little bit later about some management strategies for the neuropsychiatric symptoms coming from dementia. Just move things along here. So this is really important. I won't take too long here. So the clinical symptoms of Alzheimer's disease is the most common cause of dementia, but a patient or patient family will want to know what's the difference between dementia and Alzheimer's, right? We have to let them know that we're actually giving you a clinical diagnosis. The pathological diagnosis is really hard to determine. And we have biomarkers now. We have different sort of PET imaging that can identify some proteinopathies in the brain. But those are recent and they're not super readily available to most folks. And oftentimes folks are making clinical diagnoses. And so, Alzheimer's, we know, is amnestic, memory impairments, visual spatial variations, slowly progressive. And then Alzheimer's disease, the pathological diagnosis is amyloid plaques and tau tangles, and the definitive diagnosis is usually made on brain biopsy or brain autopsy. Language around the disorder is evolving, so intermediate biomarkers, imaging, and genetic markers can help differentiate the pathology. And the next slide I like a lot because it kind of gives an idea of how various types of proteinopathies can lead to different variants or sub-etiologies of dementing illnesses. And so it's it's really hard to tell what pathological case is causing which types of dementia. And what's the point of that is that it's really hard then to actually formulate clinical trials to see what we're looking for, because we don't know like what is actually causing the development of this dementia type symptoms. I like how it's color coordinated because I'm a visual learner. You can see behavioral variant frontotemporal dementia is mostly due to tau and TDP proteins. And some of it is due to Alzheimer's disease pathology, but again, there's really no way to tell. Much of these, some of these, I think we can now do with CSF studies and PET imaging, but a lot of this, I think, is just to let our patients know really is getting the clinical, and we may be able to get an idea of what the pathological is, but what difference really it's going to make with the treatment today, it's unclear. So case study, Mr. K, he's a retired accountant. He's concerned that his short-term memory has declined over the past year. He returns from the store with the wrong food and he needs to write down a grocery list. Paying the bills and projects take him longer. He feels as if he's lost his confidence in completing these tasks. His father had major neurocognitive disorder due to Alzheimer's disease with onset of symptoms at age 72, which was in which memory was predominantly affected. The patient had a recurrent major depression disorder 5 years ago and was successfully treated with an antidepressant, which was eventually discontinued. But lately he has been worried and down about having memory issues like his father. He exercises rarely. He quit smoking 20 years ago and he drinks occasional alcohol. On current examination, the geriatric depression score is 6, geriatric depression score on a scale of 15 is 7, suggesting mild depressive disorder, and generalized anxiety is 7, suggesting of mild anxiety. On memory testing, he scores below normal when repeating a brief story containing 10 details. Laboratory findings are normal. Brain MRI shows bilateral temporal, medial basal and lateral, and medial parietal lobe atrophy. On genotype testing, he has one apolipoprotein E4 copy. On this visit, his blood pressure is 145/90. He has been taking medications for hypertension for over 2 years. His BMI is 23, and he eats a balanced diet with daily intake of fruit and vegetables. So, okay, so Mr. K, what diagnosis would we give him based on the symptoms that he presented with? So he's noted to have subjective and objective cognitive changes, but overall preservation of his functionality. He meets the criteria for mild cognitive disorder. Family history, cognitive testing of memory impairment, and topographical biomarkers of cortical atrophy. He meets the criteria for mild cognitive mild neurocognitive disorder due to Alzheimer's disease. So we're sort of stratifying that a little bit. And I just included a little thing here of instrumental ADLs and routine ADLs and a mnemonic for that, just for informational purposes. What advice can we give to Mr. K on prevention strategies and mitigating the current risk factors for progression to major neurocognitive disorder? So his recent treated episode of depression can increase risk factors. So encouraging him to maintain adequate emotional health and routine follow-up for his mental health is appropriate. ApoE4 allele is responsible for about a 7% increase in incidence of major neurocognitive disorder. And risk factors in early life include not completing secondary education. In midlife, risk factors include hypertension, obesity, hearing loss, and in late life, risk factors include smoking, depression, physical inactivity, social isolation, and diabetes. How would you assess Mr. K's genetic risk? There's no single genetic mutation identified for dementia, as we have seen on the previous the slide there. Most cases are influenced by a combination of things. Mr. K has the following risk factors. He's got a first-degree relative with late onset Alzheimer's. So the baseline risk is 5%, and first-degree relative puts him at 13%. He's got physical inactivity, systolic blood pressure above 140, and symptoms of depression, which gives him an additional 9%. So he's got about a 22% risk factor for developing major neurocognitive disorder down the line. Some of those are modifiable, right? He could be more physically active. He could control his blood pressure better. He could have better treatment of depression, and so he could reduce his risk factors for developing major neurocognitive disorder. And so a little bit discussion of the modifiable risk factors and then non-modifiable risk factors. We basically discussed most of these already, but non-modifiable risk factors include age. Women develop dementia more than men. Family history can be determinant. Presence of homozygous ApoE proteins can show early amyloid beta abnormalities. And so those are some modifiable and non-modifiable risk factors. Most recent estimate of dementia, Lancet Commission on Dementia Prevention estimated that about the 12 modifiable risk factors here account for roughly 40% of the worldwide risk of any dementia. Going to treatment a little bit, are there any side effects to these pills apart from bankruptcy? Very true. So neurocognitive disorder treatments, very briefly, FDA has approved cholinesterase inhibitors for treatment of mild, moderate, and severe Alzheimer's disease. Donepezil, rivastigmine, galantamine. These improve cognition, daily and global function, and some behavioral manifestations of dementia when compared to placebo treatment. NMDA receptor antagonist memantine is approved for treatment of moderate to severe Alzheimer's dementia alone or in combination with cholinesterase inhibitors. It's shown to reduce some clinical deterioration in moderate to severe Alzheimer's disease, reduce symptoms such as agitation, aggression, irritability, and appetite disturbances. So you can see the curve is less steep with successful treatment if and treatment is initiated early on. But again, these are not considered disease modifiable drugs. And then disease modifying treatments, 2 have been approved by the FDA. They're both monoclonal antibodies. Aducanumab was the first novel therapy since 2003. And so, it's selective for aggregated forms of amyloid beta. FDA granted it a accelerated approval in 2021, which was kind of controversial because there were other trials that were conflicting, and the efficacy was in question. But aducanumab is discontinued in production now. It's going to be available until November of this year to folks that are already getting it. I think it was just stopped. The trials of people that were getting in trials was stopped in May, I think, of this year. Another one in the pipeline right now, or not in the pipeline, was granted approval in 2023 as lecanemab. for mild cognitive impairment or mild dementia only with evidence of amyloid beta based on brain imaging or CSF analysis. Clinical trials show some difference in cognitive outcomes compared to placebo treatment, but benefits to the patients that are getting it, you can't really perceive them because you're not getting better, but you're just not getting worse. And so what they saw, folks that were not getting it on repeat scoring, they were scoring worse than the folks that were getting it. So it indicates maybe there's some benefit to slowing progression. It's pretty expensive. It's $26,000 a year just for the medicine. And then that doesn't include, repeat PET scans, safety MRIs, infusion, and risk of ARIA, which is, the brain swelling, the image associated amyloid finding. There's more on the horizon. As of January 2023, there's about 156 clinical trials underway to test additional disease-modifying therapies. One thing that should be noted, about 99% of research and trials for disease-modifying therapy for dementia have actually resulted in failure. And so, the capitalistic pharmaceutical model would say, okay, well, that's not worth exploring since there's such a low risk. But as we discussed earlier, the market share of the growing elderly population still makes it a very lucrative, thing to seek. And obviously, that goes without saying the benefit it could bring to some folks. Another case, we're kind of running on, I don't know how we're doing on time. I think we're doing okay. Case of Mr. C, Dr. Buddy, local PCP, who you have shared with patients in the past, calls your office today to ask for advice regarding one of his patients. Tells you that Mr. C is a 71-year-old man who lives in the community with his wife. He recently diagnosed him with a mild neurocognitive disorder, and he has a two-year history of worsening short-term memory, and he won't be able to remember the conversations he had a day ago. Neither the patient nor his wife have noted any issue with dysfunction. In the past 2 to 4 years, he has started having concerns that somebody has been breaking into his house and stealing things. He believes that his neighbors may be the ones breaking in because he had an argument in the past with his neighbor about the dog urinating on their lawn. He believes his neighbor is now retaliating and doing things to scare him, so he and Mrs. C will move out. Dr. Buddy thought it'd be an episode of delirium, so he ordered some basic metabolic panel, urinalysis, and ECG. All results were normal. Physical exam was normal. He has no specific neurological symptoms. He wonders if the delusions can be related to his memory impairment or whether he should be considering the diagnosis of possible independent psychotic disorder. What neuropsychiatric symptoms are observed in the case? Patients having paranoid delusions. He has a prevalent, he's having paranoid delusion. The prevalence of paranoid delusions is about 3 to 14% in individuals with major neurocognitive disorder. Differential would be a mild neurocognitive disorder with neuropsychiatric symptoms rather than a comorbid delusional disorder. What are some pharmacological interventions that we could consider? Recommendations are strong for risperidone, olanzapine, or aripiprazole for agitation, aggression, and psychosis. Then kind of just discussing the terms, neuropsychiatric symptoms or behavioral and psychiatric symptoms of dementia. Up to 97% of persons with dementia develop some sort of behavioral and psychiatric symptoms of dementia. Depression and Alzheimer can be seen about 3 to 5 years before Alzheimer's or Parkinson's diagnosis and may be considered like a prodromal development later on in life. Most common are depression, anxiety, and apathy. Less common are wandering, sleep disorders, and sundowning, but those are the ones that are the most troublesome for the family members and the patients. Psychosis, impaired reality testing, hallucinations, delusions, agitation, which is non-aggressive, and irritability, which is aggressive, are also some major behavioral and psychiatric symptoms of dementia. All of these in combination result in caregiver burnout, increased healthcare utilization, family crises, and institutionalization. And so, what is the presumed pathology? There's neurodegeneration, there's death of neurons, there's disruption in neuronal circuits involved with emotion, which predisposes folks to develop behavioral and psychiatric symptoms of dementia. These can fluctuate over the course of dementia as it progresses. And then I think we've all seen maybe a version of this. I think Dr. Stahl has one. This is Dr. Cummings. His version here. It's kind of like the hypothesized cortical limbo psychosis pathway and dementia-related neuropsychiatric symptoms. And the general gist is, without going into great detail about it, is that there's overactivation of the mesolimbic pathway, resulting in excessive dopamine stimulatory signaling, resulting in psychosis and visual hallucinations. And so you know, what does that support? Okay, we have to address both serotonin and dopamine in combination to help reduce some of the psychotic symptoms of dementia. Other symptoms, behavioral and psychiatric symptoms of dementia can have varying different causes, and they're different for each person. So it's hard to, you know, the evidence for jumping to a pharmacological intervention is kind of weak. And so neuropsychiatric symptoms in mild cognitive impairment and Alzheimer's dementia and anxiety. And as you know, you progress from mild cognitive impairment slash major neurocognitive disorder slash dementia, the prevalence of these increase. So anxiety, depression, apathy, euphoria. Some people may say, hey, it's like a manic state. Delusions, hallucinations, agitation, and irritability. And those are some, again, with Dr. Cummings and Apostolova, some of the percentages related with both mild cognitive impairment and dementia. A meta-analysis of 48 published trials actually revealed the most frequent neuropsychiatric symptom was apathy, followed by depression, followed by agitation. And you know, apathy is pretty killer in dementia, and that kind of leads to really decreased function, not really caring about what you do, requiring a lot of prompting to do things, leads to more functional decline, you know, sedentary behavior. And so it's a challenging neuropsychiatric symptoms to address, and typically requires a lot of caregiver intervention and behavior modification rather than a psychopharmacology. Common precipitants of agitation or psychosis in folks that present with neuropsychiatric symptoms of dementia can be hunger, fatigue, pain, too hot or too cold, polypharmacy, you know, or change in medications or decrease in medications. We tend to typically decrease our pain medication in the elderly, and you know, they still feel pain, but they're not able to express it as well if they have moderate or severe dementia, which can lead to agitation. And you know, we give them an antipsychotic, it's not really addressing the pain. Physical issues, infection, discomfort or distress related to constipation, incontinence, or bowel or bladder issues, understimulation or overstimulation. Other common contributors include vision or hearing difficulties, confronted with, you know, cognitive challenging situations or demand, being assisted with or rushed to complete tasks such as bathing, dressing, or other activities of daily living, feeling a loss of privacy, modesty, or loss of control, and sensing frustration, anxiety, or other emotional distress of caregivers. And so, you know, you have somebody that's in a nursing home that requires full care, doesn't have his hearing aids, can't see, you know, is an unfamiliar environment. The nurse or orderly comes in, they're waking him up. Hey, it's time for medications. It's time to eat. Let's go. You know, you can't see, you can't hear. You're going to start swinging. And so kind of controlling some of these modifiable risk factors for agitation can improve outcomes, and you know, not lead people to come to EPS at midnight from the nursing home, and you just try to discharge them back there. Some rating scales that you can use, the neuropsychiatric inventory can assess the frequency and severity of the behavioral disturbances. There's 12 domains. It's scored out of 60, and it takes into account the caregiver distress. And the higher they score, the worse these symptoms are and require a overall behavioral modification plan. This is a conceptual model of the intrinsic and extrinsic factors which lead to neuropsychiatric symptoms. There's both a disruption in brain circuitry that's contributory, and then the vulnerability to stress and triggers. So there's patient factors, caregiver factors, and environmental factors. We have some modifiers, and so this is kind of like a visual of much of the presentation from earlier. And resulting neuropsychiatric symptoms can be agitation, psychosis, depression, apathy, sleep disruption, and others. And so, it creates a stressful environment for both the patient and the caregiver. And so the solution is, it needs to be personalized and precise for the stressors and triggers that are present for the patient. I think we have the culture, obviously, with the nature of the healthcare system that, somebody comes to the hospital, they need to leave immediately. And so generally the first thing we end up doing is then prescribing antipsychotics or antidepressants, which, are appropriate, but the root causes then ends up being missed, and the efficacy is not that great. Treatment of neuropsychiatric symptoms, briefly already discussed this. Tailored response, presumption that a single neurobiological basis for agitation and use of specific medications to give for that is kind of weak. So, redirection, reassurance, distraction, structured activities, sensory stimulation interventions, light therapy and management, and residual space planning. Treatment of neuropsychiatric symptoms, that's little. I think before any indication by FDA, Thorazine, I still add for senile agitation, given Thorazine. I could talk about some history of what it was like for folks that had neuropsychiatric symptoms of dementia prior to the development of patients' rights and stuff like that, but we'll move on. So FDA has a black box warning regarding atypical antipsychotics, basically increased mortality in the elderly patients with dementia-related psychosis. Leading to about 1.6 to 1.7 times the risk of death compared to placebo. Although the causes of death were varied, most of the death appeared to be either cardiovascular, infectious, and this is just the one for Latuda. Going forward, treatment of approaches of antipsychotic medication. After carefully evaluating and contributing an environment, we can consider other pharmacological agents. Before we do that, we need to document discussion of risk with family, including the black box warnings. Side effects need to be considered, such as sedation, falls, etc. Lowest effective dose with slow titration and response monitoring and cessation when opportunities are available, even when the symptoms are well controlled. Treatment of neuropsychiatric symptoms, most recently Bexpiprazole was approved in 2023 for agitation related to dementia. Studies were interesting in that they used a more expanded definition of agitation based on the Cohen-Mansfield criteria. In the second trial, aggression was also required as a factor for the patient population, the study population, and it was interesting that much of the trial participants were from Eastern Europe, so it brings into question if that's generalizable to the U.S. population as far as global risk factors go. Risperidone and aripiprazole trials previously, which did not get the FDA indication for treatment of agitation in dementia, used a much more restricted agitation criteria, but they concluded that at that time that agitation was too vague of a symptom. Other medication that's approved is pimavanserin, serotonin 2A receptor inhibitor via antagonism and reverse agonism. It's already approved for Parkinson's disease psychosis. It modulates serotonergic activity in mitigating the effects of GABAergic and excessive serotonergic signaling, affecting really that pathological course that we discussed here. Other treatments of neuropsychiatric symptoms, antidepressants, most commonly sertraline, citalopram, escitalopram. In one study, citalopram was equally effective to risperidone. It was more effective than placebo in the AD randomized control trial. Dextromethorphan-based therapies with either bupropion or quinidine therapies, affecting affinity to sigma-1, serotonin, and NMDA. The advancement trial demonstrated an improvement in agitation compared to placebo, about 48% improvement from baseline. Obviously, sedative hypnotics are not recommended, associated with falls, cognitive impairment, and pneumonia. I'm curious to see what the GABA-A modulators that are recently being approved for depression, what role they may have, as it's indicated that they don't carry those dependence and excessive sedation risks. And then sedative hypnotics revealed a 28% increase in pneumonia in the first 30 days. There's a lot of things in the pipeline right now to help with neuropsychiatric symptoms as well as disease-modifying therapies for dementia. These some agents that I've kind of listed here as ACP-204 targets neuropsychiatric symptoms. It's a selective antagonist / inverse agonist of the serotonin 2A, started in November 2023. Aducanumab that we discussed earlier, anti-amyloid monoclonal antibody directed towards plaques and oligomers, started trial in June of 2022. AXS-05, NMDA antagonist, sigma-1 agonist, and serotonin norepinephrine transporter, one of the dextromethorphan-based or maybe dextromethorphan-based therapy. AR1001, disease-modifying therapy targeting both neurotransmitter receptors, PDE5 inhibitor to reduce amyloid production and decrease inflammation in animal models of Alzheimer's dementia. And then KarXT, targeting neuropsychiatric symptoms via neurotransmitter receptors using a muscarinic cholinergic agonist with a peripheral anticholinergic to kind of offset the cholinergic activity. And then this is kind of a visual of all the 2024 active drug development in the pipeline, phase 1, phase 2, and phase 3. And so, we'll kind of be just waiting in the fall to see what kind of decisions the FDA makes and going forward to see what kind of options will be available. So disease-modifying biologic, disease-modifying small molecules, neuropsychiatric symptoms, and then cognitive enhancers here. Other potential targets for treatment of neuropsychiatric symptoms, some of them we've already discussed. Other ones like the muscarinic receptors, cannabinoid receptors, the metabotrophic glutamate 2 receptor, and the serotonin 6 receptors. Some of those medications that I mentioned previously are exploring research for these targets. So I didn't talk about in treatment. I didn't talk about mood stabilizers. I did want to just kind of briefly mention that mood stabilizers are pretty commonly used in agitation and dementia. There's been no like really consistent trials. Some do and some don't indicate that how efficacious they are. But one thing is for sure, they have efficacy in folks that have a mood disorder in addition to dementia. Otherwise, the mortality rate is increased with mood stabilizers, especially Depakote, with fall risk, weight gain, sedation. Okay, there's my references. All right. Well, thank you very much. Is there any questions? What I'm going to do is turn off my microphone and turn on my phone so I can hear the questions.
Thank you so much, Dr. Abbas. Very informative and thorough presentation. We'll now be promoting panelists or promoting attendees to panelists. And if you have questions, you can put them in the Q&A.
Dr. Abbas. Can you hear me?
I can hear you.
Yeah, so hi, this is Dr. Huang. Excellent presentation on dementia. So two questions, sort of, is it possible dementia is just part of normal aging? If like 33% of people age 85 become demented, that's a pretty high number.
So, prior to Alzheimer not discovering, but sort of identifying the pathological cause, potential pathological causes of dementing illnesses, that was the impression, right? That dementia is just a severe variance of normal aging. So, the jury, we're still arguing about that, right? Because the fact that we're researching so many different ways to treat and different disease-modifying therapies for dementia is we're not sure really what the pathological cause is. We know the protein pathies, the plaque developments have something to do with it, but there's just as many cases of plaque development in folks that have no clinical symptoms of dementia. So yeah, I mean, that's a good question. That was certainly the impression prior to, dementia treatment. But we do know is that what significantly is going to happen is as the elderly population increases, the percentage of those folks that do develop dementia does require, effective treatment and resources that we just don't really have right now.
Sure. Yeah, so second question is like, as far as I'm concerned, I think the beta amyloid hypothesis is pretty much discredited. So why are we still, like you were saying, we know early on beta amyloid, plaque is not either necessary or sufficient to induce dementia. So why are we still, focusing on all these drugs, to remove beta amyloid deposit as treatment?
Yeah, no, I agree with you, and that was a finding that that was a finding that was actually first documented and published in 1911, and there's still I think there's still we've seen that in the when aducanumab was first approved, the efficacy was very limited, and now I think the intention is to try treatment earlier, try to have the diagnosis earlier, and see if the early treatment removal of the amyloid plaques will lead to either decreased progression or better outcomes. In the presentation, I talked about that the perception to the folks that are getting the medicine in the trial of any improvement is not there, because they're not like seeing an objective benefit. They're just seeing no progression of their dementing illness.
Yep. Yeah, thank you so much for this excellent presentation.
Yeah, going off that, Dr. Abbas, also a very good presentation, very informative, especially with novel treatments and new treatments coming out, because these are things that we don't get a lot of education on, I think. So going off that question about we need to do these new monoclonal antibody treatments sooner or earlier in disease progression, it seems like from recent studies that the changes of dementia occur sometimes even decade before we actually diagnose dementia. Like these changes can occur very early on. Where are some of the pathways you're doing to identify it earlier to help with that?
Yeah, excellent question. So yeah, the plaque development and the neuronal changes are occurring well before symptoms emerge. And so, I think the suspicion, the family history, the family history, I think, is the primary thing that encourages folks to seek out early diagnoses. And these are some, there's several biomarkers now available that can be used to show evidence of amyloid beta in the CSF or on PET imaging. And so that's what's kind of guiding in my impression the early treatment, which is presumed to eventually help reduce the progression. I did have some data on how how long it would delay that. I think it was first presumed like it would only make like about a 6-month difference in switching from mild neurocognitive disorder to major neurocognitive disorder, but that is not available for the new monoclonal antibody that I discussed earlier.
And just to clarify, and maybe I missed this, the new monoclonal antibody, is that still targeting amyloid or is it targeting tau?
It's still meant to target amyloid beta.
Yeah, because going over what Dr. Wong said, it would make sense to have something targeting tau, though that is an intracellular protein. So I imagine anything targeting that would be very difficult and possibly even damaging to the brain, actually.
Yeah, you're absolutely right. And, I think what makes the clinical trials and having objectives to those trials, and even like, the patient selection is there's so many different proteinopathies, genetic factors that lead to the same development of the same type of dementia syndromes.
Do you find any evidence of parts of the world where dementia is prevalent, especially before the spread of vascular?
Yeah, that's a great question. Dr. Kalal has asked if there's any evidence of the prevalence of dementia is least likely, right? Yeah, I did come across some information, in countries with Mediterranean diet, low salt diets, where hypertension risk factors, obesity, diabetes are less, the prevalence of dementia in those is less. And then, the research shows, the global Lancet reports shows that incidence of dementia is globally decreasing due to how well, I wouldn't say how well, but due to like the rising educational rates and, control of vascular risk factors in heart disease. So we worked around a little bit technological, I think, solution. Well, thank you so much, everybody. If there's no more question, thank you for allowing me to present my topic, and I hope everybody has a good day. Sorry for keeping you so long.